I'm tremendously grateful to have this opportunity to discuss with you an area of interest which is something which is very near and dear to my heart. And I'm mindful you might be wanting to be at home tonight and listening to an analysis of the throne speech, but you're here with me and my heart is touched by that. What I want to do this evening is divide my talk with you largely into three parts. The first part is I want to show you and talk about how discharge planning is an important quotidian ethic, and we're going to define quotidian ethic in a moment. And then we're going to look at some of the issues that we are all facing related to discharge planning. And the last part is I certainly hope that we're going to have some discussion. That's something I very much want to have time with you to hear what your feedback is, what you're experiencing, and perhaps, as it says here, maybe some next steps on where do we go from here. I'm very grateful to Dr. Russ Upshur, who gave me the word quotidian, because it was not normally in my vocabulary, because I was thinking about discharge planning as an everyday ethic. But a lot of people are using the language of everyday ethics. And so through his knowledge of Latin, not my knowledge of Latin, I arrived at that word quotidian. And quotidian means something that recurs or occurs daily. And certainly, as we'll see in the next few moments, all our efforts at planning for transitions in care is an activity that occurs daily. In fact, if not hourly. The other thing that I'm very mindful of is I did use the word or language discharge planning in the advertisement, as it were, the flyer, because that's a language that we are quite familiar with. But I wanted to shift our language more towards transitions in care planning. Because to me, discharge planning is very much sort of a snapshot in time. Here's your prescription, here's your follow-up, we'll see you next time. Whereas transitions in care planning has that sort of longer perspective and may even be take into consideration what's happening in our hospitals, what's happening in our agencies, simply as people move from one care provider to another care provider. That too is a transition in care. So hopefully, as we speak, as I speak, we'll think of the language of transitions in care planning far more. And I believe the folks at St. Mike's, probably you've been using the language transitions in care planning as a part of your routine work. The other thing that I wanted to make a couple strong points about is certainly when we think about transitions in care planning, I mean, this is something that's important at a macro level, and we're down the street from Queen's Park. What's happening at Queen's Park and the Ministry of Health and Long-Term Care has a significant impact on what we're doing in terms of transitions in care planning. Also, what happens in our institutions in terms of policy decision making and the implementation of those policies is significant in terms of the transitions in planning. However, my talk this evening is going to be primarily focused on the micro level. The activities affecting our patients, affecting us as healthcare providers. I will say that we could probably write a few books or chapters within the book on either one of those areas. But my focus is in the one place. Now, this image, I have this image there for a reason, and the reason is this, that certainly in bioethics, there's a lot of literature written about withdrawal of life support, end-of-life care, resuscitation, etc. And I would argue that, yes, that happens regularly, but not daily, whereas transitions in care, discharges, can happen sometimes several times within an hour. This statement from the Journal of the American Geriatric Society: everyday patients with continuous complex care needs make hundreds of thousands of transitions across different sites of care. Again, that's could be within an institution, within an agency. How do we do our handoff to the next care provider? What is the communication we have, and the quality of that? Just some stats as I'm building my case around the importance of the quotidian nature of ethics. Certainly, in American hospitals, and this article speaks of 35 million hospital discharges each year. Significant, a huge amount. Mind you, contrasted with 900 million visits to physicians' offices each year. The other one I wanted to draw your attention to is a report that was put out by the Ontario CCACs about the fact that there was over 1 million patients discharged from acute care hospitals in Ontario, and this was from 2008. I'm not sure how the statistics are. And with each discharge, there is a significant mental algorithm that we work through, and that's ethical, that we're trying to come up with a best plan for the patient. In my own hospital, I was looking at some stats a while back, the fiscal year 2009 to 2010, we had 23,372 discharges. We don't think about those numbers. And then more recently, in June of this year, just for the month, we had 1,871 discharges. That's a significant number. We may think each day, who's going home today? But there was over 1,800 in my hospital that went home in a month. And that works out to roughly 62 patients a day. So the quotidian ethics, the quotidian nature of our work is significant because it's happening a couple of times per hour. Another very important point that I wanted to make too is that when we think of transitions in care, it's not only happening in hospitals, it's not only happening in agencies, although this image looks like a hospital, certainly it's happening in outpatient settings too. You imagine a patient going into an outpatient setting and being told some news about a change in their health. Well, there's a transition, there's a planning that has to go with that transition if we're doing good work. Now, so I hope I've established that there's a lot of people making significant moves through the system and that we have to be mindful of. And there are a number of issues that are taking place that we should be attentive to at each transition. And so what are some of those ethical issues at the transition points of care? Certainly capacity. We hear that, I think this is one of the areas I get consulted a lot about, is the person capable to make a decision, whatever that decision may be. Certainly, we are very much concerned about, will there be access to resources? Can the CCACs help us sufficiently with the resources that we need? Safety. By the way, this is Bob's top 20 list, it's not Dave's top 10. So you've got a few more to go with me through. Certainly the quality of social support is important, because how many times have we heard of the older person who's had a stroke, but at home they have a loved one, a significant other, who may have dementia. And how do we facilitate a safe discharge when you have those conditions? And perhaps like many of our families, we're all over Canada, all over the world, and may not have a lot of family around who can be of good and strong support. Another area that's come to my attention as a significant issue in terms of transition points and ethics is transportation. You know, these days we're not getting the ambulances paid for that were once paid for. You know, people are in long-term care homes. They now have to pay for the ambulances to come back for treatments in the hospital, or we hear in the community, sometimes people who are bedbound, they can't get into a taxi, can't get into wheel-trans, and need a private ambulance service, and they're having to pay sometimes up to, I think, $150 for that transportation. And if they're on limited income, that may be very difficult for them to get the care that they need because they can't get there. I don't know if that's true, if some of you have seen that. The other issue for me too is duty to warn. And I've worked with some community agencies in which the person at home was somebody who was known to another agency to have been sexually inappropriate with staff. And the other agency was not warned. And so they took on the care of that client only to find out that there were some pretty nasty things happening. And there was a lot of anger between agencies when they found out that the other agency knew. But there was this issue, well, should we tell? Because if we tell them, that other agency may not take on the care of this person. And so I do believe, though, that there's a duty to warn, and maybe they could have strategized around, maybe there's 2 people who go into the home instead of 1 person. Maybe it's 2 males as opposed to a female, for example. Communication of plans and follow-up and continued assessments is a key ethical domain at the transition point in care. I always will make the point that you can't do good ethics and you can't do good work unless you have a good assessment. And I'm going to come back to that point a little bit later. Certainly, an ethical value is appropriate diagnostics and treatment. Certainly confidentiality and privacy are important. And this is the Henry syndrome. Patient and family expectations. Many times the families have high expectations of the resources. The Henry syndrome is high expectations, no resources. It's coined by a friend of mine down the way from here right now. Resource allocation has come up as a significant ethical issue. And teamwork. Teamwork is a very important part of our role in planning for a person's transition. We are interdependent on each other, whether that be the CCACs, the staff in hospitals, or the agencies which are receiving people. Teamwork is vital. Now, futility here, I was not thinking so much of futility as whether someone would benefit from a ventilator or benefit from resuscitation. But how many times might you have heard somebody say, if only mom got more rehabilitation, more physiotherapy, if only dad got more rehab, he would get better. And sometimes those therapies may not be beneficial. The person may have reached their plateau. Of course, we have to decide at which point we've arrived at that. Have we done that fairly? A very important point in terms of the ethics of transition are issues related to religion and faith traditions, as we know very well, culture, language. And I'm always mindful of the person who has a religious tradition and they're being discharged from the hospital, and will they be going into a place where their language is known, where their food is known, where their culture is known, and how difficult it would be if, for example, I was being put in a place where the culture and the language is so unfamiliar. And so we're mindful of that when we create a transition and care planning plan, and yet we know that we have difficulties meeting that, given our limited resources. I'd like to insert this slide here because I think it's an important slide about post-hospital syndrome. And this was an article that was written in the New England Journal of Medicine, January of this year. It is very important when you think about that when people are in hospitals, the researchers found that a lot of patients had less than 50% of their calculated maintenance energy requirements met. They had poor sleep, much like continuous jet lag. And certainly we know the stats, and we've read other articles about the effect of deconditioning of patients when they're in hospital. And interestingly enough, when you think about those three conditions, those three areas, people end up coming back into the hospital not because of what they were originally admitted with, but because they're vulnerable, their immune system is compromised because of these other areas. And the reason I put that slide up there in amongst the slides about transitions in care is that if we are aware that this is a possibility, what do we have to say to other people when we're handing off care? And if we're receiving care, do we need to think about, okay, if this is true, what adjustment do we need to make in our care levels for people, especially in the first weeks as they arrive home? Now, this to me is probably one of the big areas of transitions in care planning and ethics, and I didn't put it earlier on, I wanted to leave it as kind of the last slide in this series, is the ethical elements of consent. I don't know if that's a rhetorical question or an actual question there. Some of you can tell me. It must relate to the specific treatment. It must be informed. It must be given voluntarily. It must not be obtained through misrepresentation or fraud. No place like home rings true in this situation. I don't know what your experience is. And so I have great challenges sometimes with the consent process, especially when we are told, and we're scripted in some ways, that we can't raise long-term care as an option. We can raise going home, going to retirement home, but we can't raise long-term care. And so have you done a real informed consent process? Don't know if some of you have experienced that. Now, so why is ethics at the transition points an important ethical activity? One, we're involved in it daily. In fact, I would argue we're involved in it hourly. There are many people who are involved with various roles: physicians, social workers, discharge care coordinators, our rehab staff, many people involved. And there are high expectations with each transition. And we know that families, I think, from reading media, etc., expect a lot from our home care programs. And we are not always able to meet their expectation. And certainly there are a lot of utilization pressures. It's significant. We have, of course, people in the emergency, we want to get them into beds, but what's the fair way to do that transition from emergency into a bed, and for the person leaving from the bed, home, or to other places? Number 5 here is certainly our values can be challenged. This is a great concern for all of us. And also working relationships can be challenged. How many times we may accuse our colleagues of not doing a full and complete job or something like that because they didn't have the plans in place beforehand, or they may not have done the assessments that were necessary. And so pressures can come from ourselves. So that's my first part of my presentation, to sort of try to establish that ethics at the transitions points is something that we do hourly, and it's a significant and important ethical endeavor. Perhaps I would argue even more so than some of the end-of-life care stuff that we deal with. Now, this slide here I want to tell you just a little story about my work in ethics. When I first graduated from the bioethics program at U of T, I was sitting around a table with some highly influential people, and this question was asked of me: in your bioethics work, what do you want to be branded with, known for? Because some of my colleagues are known for genetics, some of my colleagues are known for culture and ethics, some are known for organ transplantation. I said, at the time, discharge planning and ethics. Well, there's a reason that slide's blue, because the language was very blue. I think I heard the F word how many times used against me. Why would you be interested in that? And it was repeated. And yet, I will say to you that I had, unfortunately, this quiet confidence and assurance that I was on the right track, that because of what my colleagues, what I had experienced, etc., in these area of transitions in care planning and discharge planning. And these were the areas that my colleagues and friends, myself certainly, experienced. And I sort of lumped them together in the language of moral distress, conflict, dual loyalty conflict, and resource allocation. Dr. Zorzito, you mentioned about moral distress earlier, and we'll probably chat with that a bit. Sometimes my colleagues may not have used the language of moral distress, may not be familiar to them, but they had that uncomfortable feeling in their gut. And sometimes that's how you know when you have an ethical dilemma, because something just doesn't feel right. And the same thing with moral distress, it just doesn't feel right. And so those of us who have some training and knowledge about moral distress can speak to it. And we can speak to the fact that moral distress happens as we're working through a difficult situation. And sometimes the moral distress can be uncertainty around which direction to go. It can be also a moral dilemma, because maybe there's more than one right way to go. Yes, we could send this man home. It would be good to get him home. But going to long-term care might also be good for him, because he would have some care, some supervision. And we're on a dilemma there because we're wanting to do the best for that person. The other way of thinking moral distress too is happening as an outcome. One of the social workers at my hospital has this slide on her wall in her office, and I was actually kind of proud of her for having this on her wall, because she points to it every so often and says, "This is what I'm experiencing." Moral distress, when persons believe they know the ethically appropriate course of action, but cannot carry out that action because of the institutionalized obstacles. Or when there is an incoherence between what one sincerely believes to be right and what one actually does and eventually transpires. And so we may be wanting to do the best transition and care planning for our patients that we work with, but those institutional barriers, or as I said earlier, we cannot even raise sometimes the issue of long-term care in many of our hospitals now. And yet we know, hey, this person needs that. Or even the way that we may document where a person should go has been affected. And the effects of moral distress are quite strong, but can really, I guess, gnaw at us. And certainly it can lead us with this issue of questioning one's own judgment and reasoning. I always used to do my assessments that way. What happened to my assessment my quality of my assessments that I did before? Why is it not being respected now? What's changed? Cynicism. One looks at our hospital walls and our agency walls, and we see our value statements. We see value statements up there like compassion and trust and stuff like that. And God, how does this represent those values? Compassion fatigue and burnout. One of my colleagues said, I can't fight anymore, I can't advocate anymore, we're just tired. And depression, and certainly exit from the profession, is another outcome of moral distress. Conflict is another area that people started to lump some of their thinking around. By the way, there are not too many cartoons with discharge planning, so I had to find one, and there's another one I got. Both of these are from Stitches. Some of you are familiar with Stitches magazine. Here's your discharge and a note of apology to the nurses for you to sign. But that's not quite the conflict that I wanted to speak about this evening, and I'm hoping some of you will share the conflict that maybe you're attuned to. Do you remember this article that was in the paper in the Ottawa Citizen back in January? This person was summoned to the hospital for a meeting about her 89-year-old mother. She was given two options: put her in a retirement home or take her to the first available nursing home bed. This can be a significant challenge, especially the retirement home option, when some of our patients may not be eligible for retirement home because their care needs are too great. Or maybe it's too costly to go to a retirement home because good retirement homes do cost a lot of money, although some are very fine and wonderful places to be. Or the first nursing home bed that's available. Maybe this dear lady has cultural and language needs which may not be consistent with that first home that bed's available. Yesterday I heard a story from a social worker from another hospital, not mine, that the first bed that was available was in Muskoka. Where did the person live? Vaughan. And I thought that was pretty shabby because you imagine if the person's older and how would their spouse would get up to Muskoka. I mean, my mom and dad live in Muskoka and I go up there every couple of weeks to see my mom and dad. Can you imagine going through snowfall and so on and so forth, especially for a senior person? Here's the other story. Did you remember, if you recall the story from the Toronto Star in June? Feels he was being coerced into making a quick decision that was not in his mother's best interest. The rules are being broken, people are being lied to, no question. They are being told they have to do things that are not in accordance with the law in order for hospitals to get them out of beds. I don't know, some of you know Jamie Andrews, who was being quoted from the Advocacy Center for the Elderly. Now this situation I'm not quite comfortable with because this gentleman wanted only 1 or 2 places, and those 1 or 2 places had long waiting lists. And none of us, I think, are advocating for people to stay in hospital for a year, 2 years, because there's challenges when people stay in hospital for protracted periods of time. But nevertheless, what's happening though, and what this is symptomatic of, is the fact that we are not applying the law as we should. And that's, I think, where we're getting into trouble. And that's also going back to where I'm finding we're experiencing moral distress. I was having coffee in a shopping mall, and a physician that I know from another context who works in another hospital, he came to me and was telling me that his mother-in-law was in the hospital, and she had a fractured hip, plus she's got dementia, and her husband, is at home also with dementia, so they had 2 family members with dementia. And the hospital was telling them that she would have to go home and apply for a nursing home, but they could not apply for a nursing home from the hospital. And they were at the point where they mortgaged the house. They did a reverse mortgage, and they were running out of their funds, etc., to pay for the care providers for the 2 of them at home. And they were really struggling with what to do. Now, this gentleman was sophisticated. He knew that that wasn't what the law said. But the other thing that I appreciated with this particular gentleman was he was reasonable. He knew that he was a steward of the resources, and he was prepared to be reasonable and look at places with a short waiting list. And so he was going out and visiting to find those places which had a reasonable quality. Now, this is one of the areas which I think I've had a lot of discussion with colleagues and friends, is around our values, and around both personal integrity and institutional integrity. And this is a significant challenge for many of us. Because I would challenge you guys, by the way, you go back to your places of work, go back to St. Mike's and others, have a look at the value statements that are usually placed on the walls or on the desktops of your computers, and see what they say. And I bet you somewhere in there's things like caring, trust, integrity may be there, compassion, responsibility. And these things can really come into conflict when we want to do the best transition and care planning for our patients. One area that certainly hit home for me is this an anathema to patient-centered care at times? You say, you have to go home and it's not the best place for you. Is that patient-centered? And even the way that we arrive at the decision where the person should go is not, to my mind, always very patient-centered. Oh, and I'm glad you're here, because one of the things I'm very appreciative of is the guidebook that was written. I don't know, Maura, if you had a contribution to it, for Catholic health ethics. And I'd like to quote from here, in it's number 27 in this wonderful book, that says, "Persons receiving care should not be transferred or discharged by the care provider until there is assurance that the person is safe in leaving the service, either because they are able to care for themselves or because adequate supports have been put in place." Like, how wonderful that is that that's written. I have the book in my bag and I do read it quite frequently. I'm grateful for others who have pointed that out to me. This other language that I'm fond of is dual loyalty. The dual loyalty conflict arises when there is a clinical role conflict between professional duties to the patient and obligations to the interests of a third party, such as an employer, insurer, or the state. The Dual Loyalty Working Group, by the way, is a group of people who are working on issues related to physicians involved in executions. How can you be loyal to your patient, and at the same time you're saying they're healthy enough to be executed, and you proceed with the execution, and then you say that they're dead? And where's your obligation? Is it to the patient, because you have a fiduciary relationship with that patient, or is it to the state? And so I took the dual loyalty conflict and tried to bring it down from executions to transitions in care planning. And this is what people voiced to me, their concerns about who are they loyal to? Are they loyal to their patient, or are they loyal to the institution in which they work? I've been at Roy Thompson Home, one of the social workers from another hospital. We bumped into each other by chance, and we were talking about these issues. And these are some of the things that he spoke of in his experience of his work. He also used the language that I can get my hands slapped for saying somebody needs to stay longer, more so than if somebody's on a ventilator and we have some controversy as to whether or not on a ventilator. But asking for somebody to stay longer can be very controversial. So they had discomfort in handling those competing interests. Just a second. And I'm happy if you adopt the language of dual loyalty conflict and use it in any way that you can. Resource allocation certainly came up as an issue, but wasn't uppermost in the dialogues that I've had with people. Certainly we do question, should there be more long-term care beds, or should there be more home support? The question came up a lot about who made the decisions, who was involved in that, what was the publicity and the transparency around those decisions. And so sometimes a little bit of anger around how did these decisions get made, whether it's at the macro level in government or whether it's in our institutions. I'm always mindful of the fact that in healthcare we have such clusters of wonderfully educated people, and how wonderful it would be if we could gather the physicians, the social workers, the nurses, all of us together and look at, okay, what do we do with these difficult issues? And I believe that together we can come up with some good answers. But we have to respect the fact that we have that education, that knowledge, and that intelligence to do that. Now, how are we doing for time?
That's your copy.
Okay, so my recommendations, keeping clean, virtue with morality. I like this slide. I'm actually grateful to one of my bioethics colleagues for having this slide. That's why I borrowed it from him. I'm going to tell you a story about Linda. And Linda perhaps was my pivotal case, my index case, in recognizing an ethical dilemma and how important ethics was in terms of, at the time I will say discharge planning because it was then. Linda was a person who was living at home. She was living alone, and she was widowed. She had two very good daughters, and she was on a chair cleaning her cupboards. Well, of course, she had a nasty fall, and she broke a bone in her leg, and I'm sorry I don't remember which bone now, but it was a compound fracture, and she ended up coming into hospital, and there was a cascading series of things happened to her. Significant enough that she ended up in the critical care unit. She ended up with delirium, a bit more of a protracted period of time. She also ended up with some kidney function that was damaged because we did not, she had fluid buildup and we gave her medications to reduce all the fluids, but we didn't monitor it very well. But we got her to stable and moving out into the regular unit. And so she was out in the regular unit, and you can imagine that the length of stay for this compound fracture should have been only X amount of days. And the manager looked at the length of stay, and she yelled at me in a somewhat public place within the environment. And it was very, sort of troubled. She said, "Why isn't there a plan in place?" And I was realizing, how could I make a plan given all that has happened to her? And so fortunately, one of the good things that for me is that I knew the physician well involved, and I called her up, and I said, I was being yelled at because I didn't have a plan in place for this patient. And the physician said to me, he said, "Bob, I don't know what to do. Consequently, I'm making a referral to another specialist." Which also gave me a little sense of hope, because if the physician didn't know, how could I know either? And so the other physician, Dr. Krajewski, saw this patient on 4C, and the decision was made that the patient needed more time. And so she was transferred upstairs to one of our geriatrics floors on the sixth floor. And some weeks later, I saw this lady going home with her walker and her two daughters. Now, if I had made a decision for discharge or tried to make a plan at the moment that the manager was getting mad at me, I could have made the wrong plan for that patient. I mean, if we thought about that, at that time she was maybe delirious, the family might have felt compelled, or I could have compelled them to make a decision for long-term care, which for Linda was not the right decision. And this is where I was saying earlier about, in terms of ethics, in terms of assessments, how important it is to know our patients. And that's a fundamental to me. That in having a good pre-admission history was so beneficial to my being able to understand what her potential might be. And it also formed the basis for advocating for her. And I'll go to this other point that I think is so valuable, teamwork. Teamwork can help with the practical and ethical challenges of transitions in care. And I would say that teamwork is also an antidote to moral stress. Another point here is we need to find trusted mentors to help us review our difficult cases. Some of us have to go to joint disciplinary rounds weekly or other similar types of functions. It'd be great if you can review your cases, the difficult ones, beforehand, so that you, when you do have to present them, you can feel stronger in what you're presenting. Another very important point for me too, by the way, is enhancing communications. I'm glad Jyoti, one of our wonderful occupational therapists, is here, because we need to find ways to bridge communication barriers. Simply because somebody's not verbal doesn't mean that they're incapable. And so if we can engage them through other technologies, how wonderful it is to be helpful to them in that way. I was working with one of our occupational therapists and using the pocket talker, and we were doing an assessment, and this person was almost profoundly deaf. But the beautiful thing about the pocket talker is we could whisper, and she could hear us. It helped to protect her privacy, and helped us to work through a plan. And when we were finished, this wonderful dear lady said to us, "Thank you for caring." It meant the world to me. And her family went and bought one of these for her, because hearing aids just weren't doing it. Nowadays, with modern technology, the tablets and iPads and that can be tremendous in helping us with augmentative communication. And so I always want to encourage us to look at the role of occupational therapists, both speech-language pathologists, etc., to help us with our transitions in care planning, not just the swallowing assessment, etc., not just the mini mental health test, but bridging communications barriers. I think it's very important too to be familiar with our college standards. And most professional college codes of ethics include a statement that our responsibility is to the needs of the patient first. And I think too that our college standards gives us a voice sort of that people have worked out. Maybe we're not always as articulate as we want to be, but if we know our college standards, it helps to give us confidence and a voice to say, this is what I can do, this is what I can't do. Now, you'll still get some pushback, but it makes it a little better. And certainly I'm going to repeat this point about advocacy, that from Hippocrates onward, one of the main pillars of every professional college code has been advocacy. I was hoping tonight I actually invited people from the Ontario Association of Social Workers, but they couldn't be here, and I would have loved it if they could be, and from other associations. Because I think it's our associations that can help us, because when we have these difficult dilemmas that we're working through, and sometimes we can feel very vulnerable as staff in terms of, will I have a job tomorrow if I'm too critical of how we do things in our hospital and in terms of our policies? And maybe it's awkward for me to say something, but if my association will say, hey, here are some of the values, here are some of the principles that we need to uphold and adhere to, whether that's the Ontario Association of Social Workers, OMA, the Nursing Association, OTs and PT associations. The colleges are good, but the associations are to represent us. Another resource that I highly value, and I try to quietly tell this to patients and families, and I know others are, is pointing people towards the Advocacy Center for the Elderly. And if you haven't read this, I would encourage you to read this, Discharge from Hospital to Long-Term Care, Issues in Ontario by Jane Meadis, updated in July 2013. And you can go to their website, Advocacy Center for Elderly, publications, and I think it's the first one up there now, and read it. And it's very, very helpful to know. Especially if you're working with families who are faced with what's the right decision to make, what does the law say we should do or not do. I'm just thinking about our current Pope and thinking about the needs of the vulnerable. We need to be vigilant to address the care needs of our vulnerable. One of the areas that I've certainly heard from my colleagues, and I don't know your experience, those of you who work in transitions and care planning, that sometimes people who are from other countries, who don't speak English, who are maybe coming from countries that are oppressive, etc., they may hear our staff say, or our administrators say, if you don't make this decision, we're going to get the government involved, or we're going to get the public guardian and trustee involved, is something that I've heard. And sadly, it's the wrong use of the public guardian and trustee, but if you don't know, then you're going to say, oh my God, I don't want the government making a decision for me, I better comply. And so I would argue and want you to think very strongly about it in our work, the importance of being mindful of the vulnerable. And I think we have an added duty as healthcare professionals to be vigilant about the needs of our vulnerable. Now, almost finished. And so I'm going to conclude with a couple thoughts. One, that I hope you will agree with me that from my early part of my discussion that the transitions in care planning in its breadth and scope is a significant and important ethical endeavor. It's important as it involves a great number of team members across a spectrum of locations, facilities, and agencies. And it's a quotidian ethic as it occurs multiple times each day, impacting the well-being of many people, us, the patients, and their families. Another slide from Stitches. You're being discharged today. I'd like to think that one day, hopefully, we can help the patients to be smiling. In this case, the dear nurse is the one smiling and happy, saying, oh, thank goodness he's leaving. If that was Bob in the bed, I'm pretty sure they'd be saying, thank goodness Bob is on his way. And we're finding him that place in Muskoka. So what I'd like to do with your help is take a few minutes of thoughts, questions, issues, and then I'd like just 2 minutes to wrap up. And so I'm towards the conclusion of my slides, my talk for this evening. Would like to get a sense of your issues, your thoughts, your questions, and any next steps you might think that would be helpful. And by the way, I'm not the ethics police, so I'm not going to be saying who's right and who's wrong here.
I have an experience recently that doesn't concern the transfer out of an acute hospital. It concerns the transfer within a long-term care establishment. I'm the bursar at St. Augustine's, and one of our seminarians had a father who was admitted to the long-term palliative care at Providence Healthcare. The father seemed to have some improvement, and his demise did not seem to be too imminent. And unbeknownst, the family was really not aware of the protocol, but the father was transferred out of Providence into another long-term care institution, which apparently was very shabby, that the care was less than adequate, and the father was sufficiently aware of the fact he was in a new facility with new people in a new environment. This escalated up to the cardinal, this concern of the seminarian that we have, and I was asked to see what I could do. So I spoke with the president of Providence Healthcare, who was not aware of the circumstances and surprised to hear that this had happened. After investigating the situation, I was told the LHIN had required the transfer. It was done in accordance with their policy, and that in fact, if the patient wished to come back to Providence, he had to reapply through the normal protocol, and because he was already in an institution, he would not be considered to be too high a priority. So the whole matter was quite regretful, and I was quite amazed that once the individual was in there, although it was palliative care, they could move him out. I don't know what you think of that.
So I think the first thing that came to my mind is what was the consent process in terms of who's the decision maker, in terms of their engagement in that process. Because I can't imagine simply moving somebody out without a consent process. Or especially, I don't know, the gentleman himself who was moved out, they were not capable to make their own no. So therefore, whoever the decision maker was, or power of attorney for care, it troubles me that they weren't engaged in that process. I don't think that that's right. Other thoughts, other areas of concern, please?
First of all, I want to say I've really appreciated your talk. It was very, very good. I applaud you. You spoke about teamwork, and I know it's very, very important. However, it's the coordination of that teamwork and the coordination of the services to make a smooth transition, or whatever those transitions may be. Do you want to comment on that?
Certainly. I mean, that's a huge issue. I mean, that's one of the ones that I think, we're all very mindful of the fact that we work in silos.
Mm-hmm.
The silo of acute care, the silo of community, the silo of agencies, the silo of palliative care and long-term care. And how do we break those barriers down? Because if you're thinking about transitions in care planning and you're thinking of an effective plan, you have to be thinking down the road, and you need each partner in that process. I can't imagine how we could deal without CCAC, how important they are to the process. And yet if the communications break down, the plans break down, the care breaks down, and the person could end up back in the hospital much sooner than they ought to be back. So about a year ago, 2 years ago at the Joint Center for Bioethics, we started a process to look at integration of care. And we were trying to think of how do we work on this issue. And so we were trying to map it out, all the issues that related to that. And we found it was so huge though, and trying to break down where do we begin our work in terms of transitions in care planning and coordination. One of the things that I would like is, I wish, in spite of the politics, I wish we had a good communications ability through electronic records and being able to share that information freely. But the politics has sometimes gotten into the way of that. So that's one thing for me. But yeah, the communication and coordination is important. Good point too. Other thoughts? I'm so grateful for each of you being here tonight. It means a lot to me, by the way.
My day job's at St. Mike's as a case manager. My volunteer job is president of something called the National Case Management Network of Canada. And I have to tell you that the field of case management and defining case management as care coordination and facilitation, and then identifying the people providing that role, and they can be any of the disciplines that you've mentioned, right, are communicating and advocating and navigating and collaborating. Like, you need a person, you need in integrated care, you need to use case management, and you need to use a player who will be that facilitator, that coordinator. CCACs call them care coordinators, but you know, trying to and Health Council of Canada, I've spoken with them, and integrated care, and always what is in integrated care is some form of case management or care coordination. It's finding the role and the person to play that out.
And I think in some situations they call them systems navigators.
Yes.
Yeah.
Something that would go to your coordination issue.
But it's also structures
Yes.
that are essential.
And then your question about, you know, like, do you build it from the top or from the bottom, right? You know, we try to suggest that, if, as you suggested, if you listen to the frontline care providers, you know, and you fund things, maybe you need to listen to the frontline's answers and find the money to fund that, rather than starting at the top with the funding for a problem.
And I go back to what I said earlier, I believe we have the intelligence to find some of those solutions. And yes, also engage our patients and our families too, if we can, to help work through some of the answers to those questions. Any other thoughts, questions about this quotidian issue?
I'm always, as somebody who's worked in hospital for many years, I'm always surprised just in terms of the advocacy piece, because social workers do a lot of advocating, why it doesn't come from the top echelons, you know? Why aren't the CEOs of hospitals, who are the most highly paid, advocating at a policy level? Because we can work very hard and advocate, but the services are becoming less and less. There's no supportive housing, there's no affordable housing. We encounter this every single day, and it's heartbreaking.
It is. And certain populations, like our mental health populations, have even greater challenges.
But I also get very worried about, you know, the flavor of the day, the patients with dementia.
Right.
Then we have, let's look at the entire vulnerable population across the board in our policy.
Right.
And it's really important to address this at a macro level, you know, because the debate is not happening,
Right.
and it's hugely concerning.
I mean, arguably, I would, if I was to do another presentation, that first one about the macro level or even the meso level.
Well, I think they need to be, I don't
Either
think
interconnected.
they need to be connected.
Yeah. But the point that I want to make is some of our administrators may argue that more utilitarian ethic notion of the greater good. I have to think about all of those folks who are in the emergency. How do I handle that population? But yes, I actually believe that we could and should be working together to try to find solutions. Thank you. Sorry, I'm going to go over here.
I think that families should be brought in very quickly when the patient comes into the hospital to talk about what's going to happen. What is the discharge plan from the beginning, and have them on board. Because to wait for 2 weeks down the road or 3 weeks, however long they're in, and then say, okay, now we're going to talk about it, they are not ready for that.
And there's panic.
Exactly. In my experience, I work in the community, and I'm getting people in the hospital and then bringing them home. And it's just horrendous, because they're being told, you have to go now, you have to go here, you can't do that, and that's not right. They don't have to. And I'm there to say, no, wait a minute, we're going to talk about this.
Put the brakes on.
Yeah, exactly, and ask for a family meeting, because if you don't do that, you're in trouble.
The only caveat that I would add to that, though, is I'm always mindful of being careful of what are we dealing with. Sometimes we have patients who have a delirium, and we
Yes.
might be seeing them as being demented, and we may be making the wrong plan. And so we may need to see what the assessments determine. Are we dealing with a UTI? How many times have you seen somebody with urinary tract infection behaving really strange? Give them some antibiotics and things turn around. But if we had made a decision based upon what the picture we saw much earlier, we could make the wrong decision. However, nothing wrong with saying to the family, here are some of the possibilities that could happen. And this is what we need to prepare you for. And maybe mom was beginning to fail a little bit anyways, or maybe dad was failing a little bit anyways, so perhaps you ought to be starting to think in the future for long-term care. And then make a more concrete plan as we become knowledgeable about what is happening to that person. Sorry, who had their hand up?
There are multiple barriers, and one of the things too that we come across, of course, there is the big government piece and the lack of political will. There's also, because every group that's in wants to do a lot of short-range initiatives to see, immediate outcomes, but it's not there for the long term. And then you have the general public who has sometimes a sense of that it's their right to have access to everything, and there's some lack of knowledge, and they put the responsibilities on the system and on the caregivers. And I think there needs to be more general knowledge about how the system is, and it's constantly shifting and changing. And you're right, discharge planning begins at the time of admission, and you want to make sure that everything is always premeditated, well-informed, and so there are no sudden surprises. So
And I'm hoping-
it's a bigger problem.
And I'm hoping too that we have some earlier discussions. Maybe we'll say, hey, this is going to be a problem situation here. Maybe we do have somebody expecting more than is reasonable, and we can help negotiate some of those problems earlier. But I know one thing that challenges many of us, we're so stretched as healthcare professionals these days. And how to have a good talk in the time that would take to do that. But yet it's so important. There's somebody at the very back, I'm sorry, behind Jody first and then Jody afterwards. Yes, it's up.
Thank you again for your presentation. I have read Jamie Lewis's article, and I'm involved in a hospital position in helping families and patients with transition planning. And one of the challenges that often comes up is around choices, around long-term care, and what is reasonable. And we know that the law will allow and respects that people need to have choice based on language, culture, and preferences, and based on prior capable wishes. However, reasonable is really undefined and is personally defined. And when people do tour the homes that the hospital would, really appreciate their families choosing from, they run, and then they will tour homes that have a 5-year waiting list and say, that is the place, that's where I can reconcile the need. And even having a notion of perhaps, moving out of the hospital system, understanding the risks of remaining in hospital, not only the physical decline, the risk of infection, falls, all those kinds of things are common to all settings. But to consider waiting in one of those facilities seems absolutely not acceptable to them. The law will stand behind that. However, reasonable, I think, is it can also be a real systemic barrier. So in my organization, I've asked that we really try to engage not only at the macro level, but at the micro level, the policymakers, because it's very difficult to stand beside a family member to say that hospital, not, with us waiting for 3 days to get in bed, this is an acute care emergency. And then standing beside the ALC family to say that hospital, choice is enshrined in our law. And so for me, it's the reasonable. What is reasonable, and how do we define it, and how do we help people understand that there are what the needs of the systems are balancing the needs of the system, but also balancing what's real to them, because really they can only see their own needs at that point and what they can live with.
Yes. Sometimes it's kind of a rather myopic view. Yeah. See, I don't, from my own personal point of view, and I think my colleagues might agree with me, that we're not actually supporting that people choose the one that's 2 years, 3 years, and 4 years only. The problem for us in some ways is the way in which it's acted out in hospitals in terms of either not being given any choice at all and say you have to go home, and then we can't even talk about long-term care. To me, that's quite wrong. But I think we need to also have that dialogue at macro level around, okay, what should we do when we have such limited resources around long-term care and that we can't keep people in hospital for a protracted period of time? What is the, I want to say fair and reasonable process for that? And even does it require a change in law? And I mean, certainly if people are looked after in a good and adequate place, you might be able to live with that. It's some of the places that have waiting lists, or short waiting lists, I'm not so sure that I would want my own family there too. And
how is reasonable defined?
yes,
What can I live with? What can I do? They deserve better because they were poured into the healthcare system and have never asked anything of it. And so
And-
there is a sense of wanting the best,
Right.
even though the best is 5 years away.
And the other question for me too, on a broader level, is can we enhance home care? And I mean sustainable home care services. Not you'll get how many hours for so many weeks and then it gets cut back. Because if you can count on X number of hours for that protracted period of time, well, maybe home is viable. And get people on the waiting list for their preferred choices and get them started sooner. Sorry, Jody, I was going to go to Jody first, and I'll come to you, Dr. Zorzito.
I'm one of the OTs at Bob's Hospital, so I have the pleasure and the privilege of working with him. He's always my go-to person for moral. So I don't think I'm that old. And one of the things I wonder is if the nature of hospitalization and all that stuff has just changed so much, because one of the things that I notice a lot is expectations coming from patients and from families. So maybe years ago, what was it like? Somebody went into the hospital and they like convalesced for 3 weeks before they got better, and are people just like not very well prepared for the knowledge that now it's very different? You go and because especially I'm coming from acute care, you get your medical issues sorted and then off you go. And so people are very shocked by that, like families and patients, and then whose job is it to educate the general public? And shouldn't we know better when, like for me, for years, even when I was in school, I was reading research about by this many date we're gonna have this many elderly people, by this date we're gonna have this many elderly people. And yeah,
Yes.
yet we still don't have stuff for them.
Thank you very much. But I would agree that anybody who gets admitted to the hospital these days is sicker. And we also know that conversely, anybody who's discharged into community, that our colleagues in the community, in CCAC and agencies, are also, and family physicians, are also looking after sicker patients. So yes, the population has changed, I would argue very strongly. Dr. Zorzito, and I'll go to you.
So, I have a couple of examples. Talk about transitions in care. So, we did a little study on my unit and talked to the bed coordinators. Those are the ones that say, this patient should be in that bed, we'll cluster these over there, and we'll maximize the care in whatever way. So we said the geriatric patients, they have a greater probability of getting a delirium. Don't move them. Keep them in the familiar environment where the nurses may have more ability to know what their needs and wants are. So we actually did a study, showed that people get delirium if they're moved more than 5 times. There's 17 times greater chance of getting delirium. So we go to the bed coordinators, we say, this is the proof. You don't move the geriatric patients if they are nicely settled in their particular area. And you know what the answer is? Well, Dr. Zorzito, the emergency room comes first.
Or infection control comes first.
Or infection, well, I can understand infection control, you don't want other people to get sick. But the emergency room come first, and so wherever, or whatever the moves that need to be, so those decisions are actually taken out of our hands. And it's
yet-
distressing when you have to deal the following day with the paranoid little lady who says,